Marvin Goldfried is a distinguished professor of psychology at Stony Brook University, where he helped to develop the graduate program in clinical psychology. He's the co-founder of the Society for the Exploration of Psychotherapy Integration. Alan Francis is a professor of psychiatry and chair emeritus at Duke, and was chair of the DSM-IV task force. Marvin describes the evolution of his psychotherapy orientation as psychodynamic, behavioral, CBT, and eventually integrative. He practices, teaches, and supervises what works clinically using direct and indirect evidence base. Alan describes his approach to psychotherapy as whatever works, or no one size fits all. He was trained and taught at the Columbia University Psychoanalytic Center, but remains equally interested in brief, supportive, cognitive, behavioral, interpersonal, and family therapies. Please enjoy this week's episode.
Good morning. This is Talking Therapy with Marvin Goldfried and his esteemed colleague,
Alan Francis. Hi, Marvin.
Hi, Alan. So listen, Alan, in our last podcast, you brought up the whole issue of DBT and what that is all about, but that was really toward the end of our podcast. I'd be interested in hearing more about your experiences with DBT and Marsha, and I can share mine, and examine how different is DBT from CBT. Is it CBT with a minor twist? Is it CBT with a major twist? Is it totally different? But let's start with your experiences with Marsha. When did you first encounter her?
Well, actually, I first encountered her with you. We were in the same room going over her grants.
Oh, so you encountered her on paper, not in person.
I knew her first on paper. She had been your student. Maybe you should tell us about what she was like then.
It's interesting. She came to Stony Brook. We had a postdoctoral program in behavior therapy. And we had this even before we had the graduate program. We were gearing up for a graduate program, but there were so many people that were interested in learning about behavior therapy. And so we set up the postdoc program. And she had her degree, I think it was in social psych, and she had been interested in working with suicidal patients and wanted to know whether, and it was a hotline and stuff like that. I don't think there was much therapy. And she wanted to know whether CBT could be helpful.
Marvin, did you know at that point about her background, having been hospitalized for a couple of years?
Not at all.
Did you notice that she had cut marks, scars on her arms and stuff?
Well, she was covering it a lot, and then every once in a while she would uncover it, but it was totally unspoken. There was kind of an elephant in the room. She had not come out. Yeah. And she did come out. Her coming out was on the front page of the New York Times.
Yeah.
Which was amazing.
For those people who don't know about Marsha Linehan, she's the developer of DBT. In some ways, I guess you could say she and Tim Beck were the most influential psychologists, Marvin third maybe, the most influential psychologists in the last 100 years. Tim and I go back a long way. Marsha I met her, I guess, shortly after we were on the NIMH committee that funded her. So that story is interesting because the committee was not enthusiastic about her research project.
No, she submitted the grant, if you remember, to deal with parasuicidal individuals. And that was not the spirit of the time at the NIMH. We were told we need to deal with real patients. And the reason she was dealing with that and didn't recognize that she was dealing with borderline patients is because of her training at Stony Brook. We were very radical back in the 70s. And we rejected the whole notion of personality and personality traits because it didn't take into account situational and environmental contexts. So there was nothing in the curriculum about personality, and certainly not about personality disorders or DSM.
So this is fascinating. There were two kinds of convincing that had to occur for her to get funded and to really get her project off the ground. we had to convince Marcia that to get funded, she'd have to use the term borderline personality disorder.
Right.
And we had, and I think you and I were probably the two strongest defenders. We had to convince the committee that even though there were many fatal flaws, and that's what the committee looked for, fatal flaws in studies, even though there were lots of fatal flaws in her study because it's so difficult to study borderline personality disorder. The patients drop out of treatment. The treatment's very, very long. There were no clear outcome measures. On the scientific grounds, her study probably would never have been funded.
Right. And there was no research on this. An
There was
editor.
a little bit of research. John Gunderson had done some studies.
Well, what was it back? Did he do research? Was it controlled research? This was back.
No,
You have to remember in the mid-70s.
He was doing descriptive studies in the mid-70s.
He was, okay. We'll come back to Gunderson because that's an interesting
But
kind of thing. He was on the committee too.
and that was the important thing, that we had to convince the other committee members
Yeah.
that even though this was a very difficult area to study, it was so important from a public health standpoint that it would be negligence on our part not to fund a study that would get the ball rolling.
There was once an incoming editor of the Journal of Abnormal Psych, and his editorial was he was going to set different criteria for evaluating whether to publish an article or not. And he said, if it's something that's been researched a lot, we expect much more. But if it hasn't been, we'll cut corners. And then he went on to add a metaphor that the criteria for evaluating a 6-lane highway is very different from the criteria of somebody who is hacking a path through the jungle. So she was hacking the path through the jungle, and methodologically it was not the tightest control, but it was interesting.
I met Marcia, and I don't remember exactly how, shortly after the committee funded her research, and we became friends. And eventually I edited her books with her, wrote the introductions to them. She gradually began telling me the story so that I knew before she went public what she had been through. And the story is so inspiring.
Yeah.
Anyone who's not read Marcia's memoir should read it. Therapists should read it because it will encourage them not to give up on patients. Patients should read it because there's no better way of feeling hope in the future than to know what she went through and to realize that if she was able to come out of it, other people can as well. Basically, for those who don't know the story, she was hospitalized as a teenager for 2 years at the Institute of Living in Connecticut and was considered, she later got her chart, was considered the worst patient they had during that period of time. That she was in seclusion for much of that time. She was cutting, she was headbanging, she was as difficult for the staff as she was for herself. And after 2 years, without any progress in the hospital, she signed herself out. She realized that the hospital was not making her better. And very often, people with kids with this kind of problem get worse. A lot of cutting starts in hospitals and gets worse in hospitals. So she signed herself out. She went to Chicago. And she had a spiritual awakening, initially within the Christian religion and later within Buddhism. And that awakening allowed her to then use what Marvin had taught her in terms of psychology and her own personal experience. She was able very quickly to graduate from college, graduate from, get a PhD, to work with Marvin in postdoc way. And she put together her own experience with the learning into developing DBT. And maybe, Marvin, you could explain what DBT is like.
Yeah. So she was a postdoc, and Jerry Davison, who's now at USC, was in charge of the postdoc program. So he did, a lion's share of training of Marcia as well. And Marcia and I, in addition to clinical work and supervision, we did several research projects. We did a cognitive behavioral intervention for unassertive women, and we did a cognitive behavioral intervention for test anxiety. So, she clearly was both clinician and researcher. And by the way, I agree with you, what you were saying a little bit earlier. I think her contribution is one of the most important contributions of the 20th century.
What was she like as a clinician in those days?
She was very good. She was, there was a strength about her and a warmth about her. When I think of Marsha and how she comes across, I think of Oprah Winfrey. Except Marsha has an Oklahoma accent. But there is that kind of off-the-cuff certainty and not glibness, but certainty and humanity. She was that, and extraordinarily bright and thorough. I'm not going to use a diagnostic category, but she was very, very thorough. And what happened is that she
challenging to the teachers?
What's that?
Was she challenging?
Oh, yeah. Oh, yes. Exhausting. We would have to bring Jerry Davison in as the referee sometimes when we were designing research studies as to whether we needed a certain control group or not. I mean, you look at the DBT and you can just see how thorough and comprehensive it is. And that's a reflection of Marsha's mind.
Could you tell at that point that she was destined for greatness?
No, it was a little bit later as she came out with the preliminary model for therapy. And then Jerry Davison spoke to me and he said, "This is profound." He said, "This is going to be a changer. She's making a huge difference."
I know that I first encountered her on paper, and I felt that the grant itself had many problems with it, but the idea was brilliant. And the way she had organized the therapy, exactly what you're saying in terms of thoroughness, it's as if she had gone through each experience she had herself had. And what would I have wanted my therapist to do at that moment?
Right.
It was almost like the woman met the moment, that there was no one in the world who had the combination of intellectual rigor and training, and at the same time had actually been on the other side of the thing.
Yeah. Interesting. It's kind of like a response to those mental health workers who screwed up her treatment. Here's what you needed to do. So it was not only wanting to give back and everything else, but also her uncanny ability to empathize and have compassion, because she was there, she lived it. And, that's how you have compassion. That's how you have empathy. Somebody says something and then you kind of relate to an experience that you have had. But the experience of difficult patients, borderlines, and I don't like that term for so many reasons, because it's pejorative, but also I don't know what the hell it is. John Clarkin once indicated how many different ways somebody could be diagnosed as borderline.
93.
How many? 93.
93.
Right. And it's just that these are hard people to deal with. And I think what happened was Marsha learned CBT, and then she went out and started to practice. And the patients would come in with their problem, and she was specializing in these borderline patients, difficult to treat patients. And she found that it was not working. And she was dumbfounded. It's like, what do you mean this is not the problem? You just told me this is the problem. What do you mean it's not the problem? And then they would go off and something else is the problem. And it was like she was confused. And she didn't know what the heck was going on until she had an epiphany. And the epiphany was, these folks are born with a constitutional emotional dysregulation issue. They can't control their emotions. And they get criticized for this. Oh, come on, you're overreacting. Or, oh, come on, you're too emotional. Oh, would you stop that already? As if they could control it. So they grew up being criticized for who they were. And of course, Marsha was able to grasp that insight.
Marcia came from a very renowned family in Tulsa. They were pillars of the community. Brothers were big, handsome business people. Her sister was beautiful, and she experienced herself growing up as the kind of ugly duckling.
Yeah.
She just did not fit into the milieu, the family milieu, the town milieu. She was just out of place and felt it in a way. When she originally was hospitalized, though she hated being in the hospital, in a way that felt more like where she belonged than in her family, because she just did not feel up to the standards that everyone else so easily achieved. I think one way of looking at this is that Marcia's first patient and toughest patient ever was herself.
Yes.
And it's kind of like the founder of many schools of religious or academic thought, that she had a kind of experience in Chicago, the spiritual experience in Chicago, that allowed her somehow or other to get distance from who she had previously been, that desperately damsel in distress in a seclusion room at the Institute of Living, banging her head against the wall,
right,
that she somehow or other she was able to see that person with the objectivity necessary. What does that person need? And able to treat herself.
Right. And the way she treated herself was very, very different from the way mental health professionals or family members and other people treated her, which essentially was telling her there's something wrong with her. And what she did is like, there's nothing wrong with me. Accept me for who I am. And she got that through her religion. She got that through Buddhist retreats. The whole notion of acceptance.
But with the dialectic.
Yes. I
have to change.
Yes. That is
Zen cone. I can accept myself. I can validate myself for who I am now. But at the same time, I have to change myself.
Yeah.
And
profound.
And I think the other thing that's very profound in what she did, and actually Tim Beck, before he died, followed the same pathway, that she injected a kind of spirituality, not religion so much, as a sense of therapy also seeks to help people find meaning in their life. It's not just the application of techniques and people get better. They also have to come to see the world differently and see themselves differently and find meaning where previously things seemed very hollow and empty.
Yeah.
And Tim Beck did the same thing. In the last 10 years of his life, he worked on modifying cognitive behavior therapy to include elements of recovery, to help people not only deal with symptoms, but also to help them find meaning in what they're doing.
Well, it's interesting, Alan, that you bring up the notion of meaning. Somebody once said, some psychoanalyst once said, and you may know who, because I only heard it in passing, that psychoanalysis is really a therapy of meaning in disguise, of helping the patient discover a different meaning. I don't know who said that.
I think that was Viktor Frankl.
Yeah.
And he had experienced his meaning in the most...
in a different way, right.
Through the concentration camp experience.
Yeah.
I think it's a tremendous addition to, like, I always used to talk about the biopsychosocial model, but I've learned now to call it the biopsychosocial spiritual model. And I'm the least religious person imaginable, but being not at all inclined towards religion doesn't mean you can't be inclined towards the search for meaning in life, the search of beauty in life. And that's something that's added to and beyond the usual technical features that we think of as psychotherapy.
Yeah, yeah.
Marcia went on after her work with you to become a star. And I think modestly we helped some in funding that grant. She understood something very important, that to be accepted, what she called dialectic behavior therapy, to be accepted, dialectic behavior therapy had to have scientific legitimacy.
Right.
Now, the actual studies she did were pretty modest, very small ends, not terribly dramatic effects.
And she was the therapist. And the question was, how much of this is DBT and how much of this is Marshall Linehan?
Well, Marcia developed an amazing training program, and I'll tell a vignette about that. But I think she trained, I would guess, thousands of therapists. And she had the ability somehow to take her own unique experiences and unique charisma and to endow other people with the confidence to work with very difficult patients that otherwise they might not have had. So and this is always a problem, like a founder of any therapy. Will the therapists who follow be able to do the therapy, or is it the personality that's unique to that person? Mm-hmm. But I think Marcia, and maybe this is a way of putting it, most therapists didn't want to treat the kinds of patients who she wanted to treat.
Absolutely.
They didn't want to treat what she had been. Worst patient at the Institute of Living. She gravitated to helping that population because she had been through it herself. And what she did I want to say almost magical way was to convey to people that they could do this work with difficult patients, that you shouldn't give up with a difficult patient, that the most satisfying part of your work would be the help. If you treated easy patients, they get better anyway. Why feel good about that? If you were able to work with someone who had the kinds of severe problems she had had, and if you could help them move along, that was special. And instead of avoiding difficult patients, thousands of therapists were trained by her specifically to work with this previously neglected population.
And thousands of patients who would not have gotten good treatment have been getting better treatment.
I'd say,
and I'm not putting Gunderson's treatment. I happen to like John Gunderson's work, and she's looking at the clock. We're not going to be able to get to that, but that's okay. I think this is interesting and this is important. I mean, knowing the person behind the intervention and understanding that, I think, can give you a deeper understanding of what DBT is about. I don't think people have this deep understanding. They say, oh, it's a good thing and it's laid out, and we have workbooks and we know what to say, so we're going to do that. But there's so much more, as you're indicating, to DBT.
I think maybe we should stop here, but maybe we should discuss DBT next time because we didn't really get around to it.
We didn't get around to the question I raised. How is it different? How is it different from CBT? And is it just a mere acceptance?
I think to close, what do we take away from Marcia's work? We're going to next week describe the techniques more, but to me, her life is in some ways even grander than her legacy.
Yes.
That anyone, read the memoir, anyone who gets to know what she went through and who's having similar problems can no longer feel as hopeless after reading the memoir than they felt before. She's a tremendous inspiration to patients. And as far as therapists are concerned, I really have respect. The most respect I have is for therapists who want to treat the most difficult patients.
Yes. Well,
I think if you want to treat only easy patients, anyone can do that. If you really want to get involved in a career that means something, you should gravitate to treating the most difficult patients.
Yeah, there are many therapists who are committed to their careers. And while Marcia did obviously have an eye on her career, she was committed to the patient. And she dedicated her life to people who were suffering. So let's end. You want me to cap this with a nice little quote from John F. Kennedy?
Why not?
Okay, his inaugural address, and I'm paraphrasing here. He said, any person can make a difference, and every person should try. And Marcia's a wonderful living example of that. Okay, Alan, have a good week. I hope you are able to shape up your new quarters. I know that you've been trying to unpack stuff and find beds to sleep in and things like that. And hopefully by next week you will. And next week we'll continue with talking about DBT.
Yeah,
Stay safe.
I really love talking about Marcia. In a way, I love Marcia. And it's nice to bring back these memories. Thanks, Marvin.
And it shows. Stay safe.
Bye-bye.
Bye-bye.